Hey guys, for those of you who don't know me, my name is Jane. I'm one of the PGY3s, and I'm going to be talking about, like Dr. Wells said, victims of domestic violence in the ER. Just wanted to take a moment to thank the social EM team, specifically Drs. Christoph, Dr. Lavadera, and Dr. Kendall with their help with this lecture. I'm going to start off like we usually do with patient presentation. We have a 37-year-old female with no significant past medical history who presents status post-assault. Initially, she doesn't want to tell you what happened. She says she doesn't remember, but then eventually, as you keep talking to her, she tells you it was her husband who did this. You ask if she feels safe at home, and if she wants to report it, and she says no. And then you offer her a social worker, to which she replies no, and that's kind of the end of your interaction. So now I'm just going to talk about, so that's exactly what I'm going to talk about today, domestic violence and victims of domestic violence in the emergency department. Give you some stats, which are pretty shocking. Talk about screening in the ER, what we can do as ER physicians. And then give some resources that we can use and give to our patients, and then just summarize everything together. So what is domestic violence? Domestic violence is a pattern of coercive, controlling behavior that is a pervasive, life-threatening crime affecting people in all our communities, regardless of gender, age, sexual orientation, race, ethnicity, religion, social standing, or immigration status. It can include things like hitting, slapping, kicking, or any other kind of physical violence, forcing you to have sex if you don't want to, or to do sexual things that you don't want to, threatening to hurt you, your children, or someone you care about, or your pet, and constantly insulting and criticizing you, or stalking obsessively, checking up on, or otherwise trying to control your behavior. As the wheel illustrates, abuse is cyclical in nature. There are periods of time where things may be calmer, but those times are followed by a buildup of tension and abuse, which usually results in the abuser peaking with intensified abuse. The cycle then often starts to repeat, commonly becoming more and more intense as time goes on. Each relationship is different, and not every relationship follows this exact pattern. Some abusers may cycle rapidly, others over longer stretches of time. Regardless, abusers purposely use numerous tactics of abuse to instill fear in the victim and maintain control over them. That's right. I'm just going to go over just some stats, which I thought were pretty shocking. I checked multiple times to make sure these were current stats, but they are. So of all the women treated in the ER, it is estimated that 2.2 to 12% present with injuries related to acute interpartner violence. On average, nearly 20 people per minute are physically abused by an intimate partner in the United States. And during 1 year, this equates to more than 10 million women and men. 1 in 3 women and 1 in 4 men have experienced some form of physical violence by an intimate partner. This includes a range of behavior from like slapping, pushing, shoving, and in some cases might not even be considered quote unquote domestic violence. 1 in 7 women and 1 in 25 men have been injured by an intimate partner, and 1 in 10 women have been raped by an intimate partner. There's not a lot of data on male victims. 1 in 7 women and 1 in 18 men have been stalked by an intimate partner during their lifetime, to the point to which they felt very fearful or believed that they or someone else close to them would be harmed or killed. On a typical day, there are more than 20,000 phone calls placed to domestic violence hotlines nationwide. In terms of stalking, 19.3 million women and 5.1 million men in the United States have been stalked in their lifetime, and more than half of that number is, or 60.8% of female stalking victims, and 43.5% of men reported being stalked by a current or former intimate partner. And then a study of intimate partner homicides found that 20% of victims were not the intimate partners themselves, but were family members, friends, neighbors, persons who intervened, or law enforcement. And 72% of all murder-suicides involve an intimate partner. When talking about domestic violence, it's also really important to talk about the special populations, specifically the LGBTQ community, immigrants, the LGBT population, and people with mental illnesses, as these populations may be more cautious when approaching medical providers, police, or other courts due to past experiences related to discrimination or abuse. Immigrants and non-immigrant communities experience domestic violence at similar rates, but individuals without citizenship status or other forms of documentation may face heightened risk of as a result of factors like language, social isolation, lack of information or financial resources, cultural beliefs, or fear of deportation. So what can we do as ER providers to help our patients? The first step is screening. Circumstances that should increase concern for intimate partner violence include multiple visits for injuries, multiple injuries in various stages of healing, patterned injuries such as slap marks and defensive injuries, injuries that are inconsistent with the history provided, and an overbearing significant other. When evaluating injuries, the potential for intimate partner violence must be like at the top of your mind, something you should be thinking about. Otherwise, you just won't think about it. Several validated screening tools are available in the ER, and EDs have certain policies and procedures in place to screen for intimate partner violence and provide appropriate resources. All the screening tools evaluated by the USPCF are directed at patients and can be self-administered or used in a clinician interview format. So we can be doing these things. And the 6 tools that have shown the most sensitivity and specificity were the ones provided here, which is HITS, which stands for hurt, insult, threaten, or scream. OVAT, which stands for ongoing violence assessment tool. STAT, which stands for slapped, things, and threaten. HARK, which stands for humiliation, afraid, rape, and kick. There's 2 more, but we don't have to go through all of them. Let's see. The next thing I want to talk about was pattern injuries, specifically things you can watch out for. A pattern injury is an injury that possesses features or configuration of an object or surface and produces a mirror image of what caused it. They can be grouped into 3 types based on their source, whether that's a blunt force, a sharp force, or thermal. Pattern injuries are consistently reproducible. Many objects and surfaces have been implicated in causing pattern injuries. Common objects include looped cord and wire, clothes iron, curling iron, a cigarette, a tire, a belt or strap, tools, an open hand, fingertips, fingernails, carpets, teeth, ligatures, and shoes. It's important for us as ER physicians to recognize pattern injuries in the case of violence, so that the offending object can be identified and recovered by law enforcement and linked to the patient and the perpetrator. And it's really important for us to document precisely the injury of the injury itself, as well as its location and wound characteristics to help with future law enforcement. So what if your screening is positive? If your intimate partner screening is positive, patients should be screened for risk factors for lethality. Risk factors for domestic violence homicides include attempted strangulation, estrangement from the abuser, and pregnancy. The risk of becoming an attempted or completed femicide victim is 3 times higher for women abused during pregnancy and 7 times higher for non-fatal strangulation victims. Perpetrator red flags include alcohol and drug abuse, access to firearms, use of firearms during previous domestic violence incidents, and unemployment. And perpetrator problem drinking was associated with an 8-fold increase in partner abuse and a 2-fold increase in femicide and attempted femicide. This is just another quick screening tool. It's adopted from a longer questionnaire, which it screens not only for intimate partner violence, but it screens specifically for the lethality of that violence. So what are our barriers? Obviously, this is super important for us to think about in the ER, but we do have barriers to consistently screen our patients. These barriers include time constraints, discomfort with the topic, fear of offending the patient or the partner, the need for privacy, perceived lack of power to change the problem, and misconception that regarding a patient's patient population's risk of exposure to intimate partner violence. Just as important it is to recognize those barriers, it is just as important to overcome them. Next up is the potential management and resources of our victims of domestic abuse. These include safety planning, stalking and safety, what resources county has to offer, and then I was going to talk about a specific website that was referred to me by Dr. Kendall. In terms of stalking or safety, it's good to know that a patient that's currently being stalked can file a petition in family court for an order of protection. They don't need a lawyer for this, and they can apply for a confidential address through the state. Both things that are very easy to establish and just look up online. Next, safety planning. There's multiple websites that kind of go through exactly how to start a safety plan. This specifically includes things like safe words that you can tell your family and friends, a shelter that the patient can go to in the setting that they feel extremely unsafe, and then a possible emergency contacts and where they can go in the setting they feel like they're in a lot of danger. So these are things that you should talk about with your patient or offer to them. It's a very extensive. I try to make a safety plan myself, and it takes quite a while, but it's an important thing for them to do in the setting that they're worried for their own safety. In terms of what county has to offer us, we have a specific domestic violence care coordinator, Ms. Mitchell. She's in the B building, room 7120. Obviously, you can always consult social work, and social worker come down and bring the appropriate literature. But I do think it is important to remember that many of our patients can't take that literature home because of the risk of their retaliation by their partner. So it's also our job as their medical providers to provide them with resources, whether that be online or like a phone number that they can call, just so that they can get whatever help they need, not just from a piece of paper. So when I was Googling exactly what resources are available, there are a lot. Simply just Google domestic violence and you'll come up with many lists, including, but not limited to, the emergency intervention services provided through the state. They have their own large list of potential resources and programs. Going through this particular list, the non-residential domestic violence services are offered via contracts with the community-based providers, offer services like counseling, advocacy, community outreach and education, housing and aftercare assistance, as well as financial development and job readiness. These programs collaborate with the family justice centers located in Brooklyn, the Bronx, Queens, and Manhattan. The No Violence Again program assists domestic violence survivors seeking emergency housing from the Department of Homeless Services. The Domestic Violence Liaison Unit provides domestic violence assessment and crisis intervention at HRA job centers. And the Anti-Domestic Violence Eligibility Needs Team, or ADVENT, is a specialized case management unit located in 3 job centers providing public assistance, case management, and engagement services. And then finally, the Domestic Housing Support Services works with domestic violence clients and shelters eligible for HRA housing subsidy programs. Like I said before, you can find tons of different resources when you look online, to the point where I think it's a little bit overwhelming. For me, when I was looking, I didn't even know where to start, and I can't imagine how hard it is for our victims to decide where they should start, whether that's filing a petition or making a safety plan. I don't know what I would start with if I was in these patient situation. Dr. Kendall actually referred me to this specific site, Safe Horizon, where I talked with their vice president about kind of what I should tell my patients their first step should be. And they suggested a hotline. So the hotline here or at any other site is the best place to start, as there's somebody available 24/7 to talk with the patient, with the victim, about what they should do, whether that be seeking shelter or making a safety plan or filing in court. They would better know than I would, or any of us would know, where to start for each specific patient. In terms of, so this is a great place for us to start when trying to refer our patients. Otherwise, I asked what we as ER providers can do to kind of push our patients to seek help, because a lot of times when talking to these patients, they don't really necessarily want social work. They kind of leave before they can get a full evaluation, just like I talked about with my initial patient presentation. And she said, really, it's just time and taking that moment to talk to your patient. Maybe you're the one person that gets to them more and convinces them that this is the time that they should ask for help. So there's not really much you can say or do to help them say, but maybe what you say will be that one time that really helps them. So in summary, domestic violence is more prevalent than we realize. Yeah, just going through those stats, I was shocked at how much more prevalent domestic violence was than I thought. And take the time to screen your patients for signs of abuse and offer your patients resources early on during their ER visit. Just take the time to talk to them and see if you can figure out a way for them to seek help. Thank you.
I want to make a comment. I think a couple of things. One, state by state handles domestic violence, interpersonal violence very differently. So just know when and where you're practicing, kind of how that's handled. In some states, it's kind of a mandatory reporting, or police will get involved. No, in New York, it's not. And also the NYPD's policy is that if they respond to a domestic violence situation, they usually take both parties into custody. And the reason they do that is to actually separate them and give the potential victim an opportunity to get help and get away. So just be wary of that for you guys. When we see a patient who's under police custody in the ED, that doesn't always mean that they did something wrong. They could be a victim of abuse. So sometimes, you know, we get blinders on, we're biased by that, but make sure we screen those people as well. I haven't finished it, so I don't want to say that, but there's a Netflix series Made. If anyone's watching that, I think it's really well done and palpable in terms of, and talking about other types of domestic violence than physical. And I think it does a good job with that. And I think that's a good thing to remember for us, that screening for those things could be an early finding that might go towards physical abuse.